This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 89 for August 23rd, 2023. We're calling this one Health Literacy and Plain Language Pediatrics. I want to welcome all of you to the program. So we have another really important topic for you this week, and it's another one that really applies to everyone in healthcare, regardless of your role or the population of patients and families that you serve. And that is because health literacy and the use of plain language is really important for everyone. And today we're going to explore why health literacy is important. Hopefully we'll help you become a believer. And we will share tips and tricks for incorporating plain language in your conversations, educational materials, and clinical teaching. To help us with the conversation, we have two plain language experts with us today. In fact, they make up our plain language panel on Plain PediaCast without the CME, which is our podcast for parents. They've been guests actually on 21 episodes of that program, helping us cover complex topics with plain language. So who are these folks? I'm glad you asked. They are Dr. Marianne Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital. Before we get to them, let's cover our usual reminders very quickly. Don't forget you can find PediaCast CME really wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of that education credit, it's really easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, of course, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice, which I mentioned for this particular episode really includes everybody. Complete details are available over at PediaCastCME.org. Also, I want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We will get Dr. Marianne Abrams and Dr. Alex Rakowsky settled into the studio, and then we will be back to talk about health literacy and plain language pediatrics. It's coming up right after this. Dr. Marianne Abrams is an assistant professor of pediatrics at The Ohio State University College of Medicine and a pediatrician with primary care pediatrics at Nationwide Children's Hospital. Dr. Alex Rakowsky is an associate professor of pediatrics at Ohio State, associate program director for our hospital's pediatric residency training program, and a pediatrician with Olentangy Primary Care at Nationwide Children's. Both have a passion for improving health literacy and implementing plain language in conversations, educational materials, and clinical teaching. They're also frequent guests on our podcast for parents, a plain PediaCast without the CME. In fact, they've appeared in 21 episodes on that podcast, and all of those episodes incorporated plain language in our conversations. They're in the house once again, this time to share the importance of health literacy and plain language, and to share tips and tricks for improving patient satisfaction and health outcomes in pediatric medicine. So let's give a warm PediaCast welcome to our guests, Dr. Alex Rakowsky and Dr. Marianne Abrams. Thank you so much for visiting with us again.
Hi, Mike. Always a pleasure to be here. Hi, Marianne.
Hey there, Alex. Hi, Mike. Great to be here. Thanks.
Yeah, so good to talk to you guys once again. Let's just get right to it. And Marianne, give us kind of a foundation. When we say health literacy, when we use those words, what exactly are we talking about?
Thanks for that chance to kind of step back and talk about health literacy and why all this plain language and all these different podcasts we've been doing are so important. Health literacy is kind of a fancy word for what has been looked at from a health perspective and a research perspective and what can we do about this perspective for more than 20 years, 25 at least. And basically, health literacy is now divided, if you will, into two different kinds of health literacy, but together they make up what health literacy actually is. So one part of that definition is individual health literacy. What a single person brings to a health conversation or looking for health information or listening or what questions to ask. And that individual definition of health literacy is really the ability of a person to find, understand, and use information and services to take care of their own health or their family or friends or loved ones. And it focuses very much on what the individual, their abilities and their background, their language, all these different things. But the exciting thing is that we now have a definition of what we call organizational health literacy, which is looking at the healthcare system. And that now is starting to look at hospitals, clinics, dentist offices, health departments, community-based organizations that provide education or services to improve the health of communities. And what we've realized is that we, us health system people, have a responsibility to make our information clear. So the definition of organizational health literacy is the extent to which health systems equitably, meaning for everyone, not just certain groups, enable and make it possible for people to find, understand, and use health information to take care of themselves. And those two things working together are what really make up health literacy.
Yeah, that's a fantastic definition. And I love that you divided it, really incorporated personal health literacy and organizational health literacy. And I would imagine we could say the same thing as we think about like an organization. A whole family unit also has a certain degree of health literacy, and even communities as a whole can have either more health literacy or less health literacy. And then because health literacy is used to make decisions on healthcare, then we can get into disparities between families or between communities because there's differing levels of health literacy within those units, whatever it is that we're talking about. And then, so disparity is one reason why health literacy is important, but there are lots of reasons why this is an important concept to understand and to want to enhance. So, Marianne, what are some of the reasons that health literacy is important?
There are years and years worth of research and data that really do show that limited health literacy is associated with all kinds of health consequences. So if you're struggling to either find information, read it and then use it, it means that you're at risk for less healthy behaviors. And these studies have shown more people with smoking, less healthy diets, things like that, less use of preventive care, like getting all the vaccinations you need or being screened for cancer, like a mammogram for breast cancer, less knowledge about how to take care of your own health, like your asthma, your diabetes, your heart failure. And it also impacts things like informed consent and really understanding the choices you have in terms of what kind of health care or whether you want to have a surgery or a procedure or take a certain medicine. If you don't understand, how can you truly provide what we call true informed consent? And then at a even more specific level, we know that there's a lot more mistakes made in taking medications, like not understanding the dosing or the timing or the interactions between drugs, more use of hospitals, emergency care, less. Some conditions have even more deaths associated with limited literacy, more hospitalizations, and more healthcare costs.
Yeah, so really lots of reasons why health literacy is important. Another one of those is actually patient satisfaction, right? So the more that someone understands and can make decisions based on evidence and understanding, the more they are satisfied with their care that their physician and a medical team are providing for them. Alex, I'm going to bring you into the conversation. Then what are the consequences of low health literacy?
So Marianne already talked about a lot of these, about not taking your medicines appropriately, et cetera. So I'm going to basically drill down a little bit more. So starting at the very top. So the worst possible outcome is mortality. And there have been studies in adults that mortality rates tend to be higher for a fair number of chronic illnesses in adults if there is a correlation of a low health literacy. We don't see as many issues with it in pediatrics because fortunately our mortality rates are a lot lower. But if you look at it, the one place where we do see a lot of deaths in the NICU because of prematurity, there have been studies looking at prematurity being more common among families where there is a low health literacy. Is it because of less medical care, medical conditions or chronic conditions not being taken care of during pregnancy? Then working sort of your way down. If you look at chronic illness, again, more of an adult data, but chronic illness is worse outcomes, especially asthma, cardiac illnesses, et cetera. And there's some literature looking at it from the pediatric perspective, especially looking at asthma, diabetes care, and also some like beginning literature and some of the more chronic like autoimmune diseases where the children with either like say celiac or Crohn's, rheumatological conditions that have worse outcomes long-term if there is a health literacy issue. Working my way down or more broadly, for kids who do have an issue, it takes a longer time to get diagnosed if you have something more chronic. If it's hard for the family to kind of express their needs or to understand the next steps, they'll be coming back in over and over to kind of get a diagnosis. And there's a disconnect between what they're looking for or what's really going on and what the physicians are hearing. So that disconnect leads to a longer time to get diagnosed and a longer time to really manage a chronic illness well. And then lastly, looking at it at a really broad perspective, there's studies showing that you have less ability to be seen. These patients tend to not have as much primary care continuity. They have less time with the providers because if it's difficult to kind of express your needs about a concern, there's less time blocked off. The providers, we all rush, to be very honest, because it's a busy day. You're like, okay, I'm not sure what you're exactly saying. So you kind of go with the least intrusive or like the best possible outcome and move forward. And you may miss it if somebody can't express themselves or understand what you're trying to express back to them. So it goes from mortality all the way down to amount of time that you're spending with a provider.
Yeah. It also, and this kind of goes along with what you were saying with access to primary care. I would imagine that then would lead to an increased utilization of emergency departments and needing to be admitted to the hospital for something that could have been prevented. And so that combines to increase the cost of the delivery of healthcare because folks are using the higher, the things that are always available, like emergency departments. But we know that getting your care there actually costs a lot more than seeing a primary care physician.
And both of us do urgent care, and you do ER as well. But so I think we have a very high opinion about what we can do in urgent care and ER, but it's not the place to go for continuity of care. And also, it's not really the place to go to get fully diagnosed with a more esoteric or a more chronic illness to be diagnosed. So I think it leads to frustrations in everybody's part. And I don't like using the term time wasted, but there's a lot of time wasted for some of these families and patients to get an appropriate diagnosis, explained to them, and then managed. I mean, there's some studies that have looked at like rheumatologic conditions, like I think mostly adult, 4, 5, 6 years to get diagnosed appropriately and then controlled, when this could have been controlled with probably better health literacy and to begin with on both ends. Could have been done in a tenth of that time. Yeah. So I think it's just a frustration that people feel not being able to communicate, and vice versa, us communicating with the patients.
Yeah, absolutely.
And I'd like to tag on to that. It's the same idea, but the flip side. So someone who has a diagnosis, a child or an adult even, with a relatively mild illness, like a cold, right? Especially parents bring their children in and they're worried. Do they have a fever? Do they have something more serious? Do they have an ear infection? Whatever. And we appropriately believe this is caused by a virus and it will get better on its own. And we tell them things that make total sense to us. But we say, if he's not getting better, give us a call or have him come back, bring him back. And in our own minds, we know exactly what we mean when we say, if he's not getting better. We expect this cold to last 10 days, it may get a little worse before it gets better. It's going to go away. A parent who cares deeply about their child, after 2 or 3 days, he's not better, brings them back. And we say, he's fine. It's going to go away on its own. So it's just a very simple thing. It's sort of an example of jargon almost. It's an easy everyday word, but we don't explain it clearly. And when we talk about waste, now we've taken an appointment that another child could use. The parent has missed work or had to get childcare for their other children or sat in the waiting room for an hour. The child maybe missed school or had to come in too. So there's all of that surrounds the importance of needing to be really clear in how we communicate and making sure we're understood. And we'll talk about that.
I think it leads almost to this, like a subconscious lack of human connection, where if I have a patient, I'm thinking urgent care, we're busy. This is a head cold. Your child's going to be better in 3, 4, 5 days. But I didn't do a good job of expressing it to that family. They're worried after 24, 48 hours. And we see them back in urgent care. And then the family's like, you don't care because you told me it's just a head cold and it's not acting just like a head cold. I'm thinking, you're 2 days in. What's the big deal? And all of a sudden, there is a subconscious disconnect where that family doesn't really trust you a whole lot. And you're sort of like, I'm not sure what else to do here. And even though it's not verbally stated, I think it leads to some complications where there becomes a mistrust on the part of those families and patients with us. And then that makes health literacy so much harder to kind of establish.
Yeah, absolutely. As we are considering low health literacy, which is really what we're kind of talking about right now, I just wanted to mention some stats to sort of bring this to light. And this is another reason why talking about this is so important. According to the U.S. Department of Education, the National Center for Education Statistics, the last survey that they did of the general public, they found that only 36% of American adults have basic or low health literacy, and only 12% of American adults have proficient health literacy. So, the vast majority of people are kind of between basic or low and proficient health literacy, but we'd like to move certainly more than 12% of the population to proficient health literacy. And their definition of proficient health literacy was skills needed to navigate complex health systems, engage in complex medical discussions, and fully participate in managing their health. So we have a long way to go to get to get folks more proficient about talking about their health. And that's one of the reasons that we're having this podcast today, to just highlight the importance of it and bring you some tips for improving the health literacy of the patients in your practice.
Yeah, Mike, you just hit a really important point that 12% are proficient among U.S. adults. And proficient sounds like, oh my gosh, you're really a mega star in this. But that general definition of what proficient means, when they turn that into what that actually looks like in real life, those are things that we ask people to do every day. Like when you're getting a job and you pick your health insurance package, you have to be able to figure out on the table how much you're going to pay if your family has 5 people in it, whatever. These are not like reading heavy-duty research articles. So the fact that only 12% of U.S. adults are proficient means that about 90% are not. So we have this incredible healthcare system that 90% of people really cannot function well in. And that's the whole rationale behind what we'll be talking about in the not too distant future on this call. What do we do about that, and how do we approach that? That 90%, the opposite of the 12% is really important.
Yeah, absolutely. We talked about disparities in health literacy, and especially if you're looking among groups. And this can be helpful because someone doesn't come into your office with a sign around their neck that says, I have low health literacy. Like, you can't tell just by looking at someone. But there are risk factors for low health literacy that we can identify. And of course, we don't want to stereotype people, but when there are risks among certain groups, it's important to know that. Because then there's an increased risk that your patient is going to have low health literacy. And so this may be an encounter where you want to really make sure that you're connecting with the person and explaining things in ways that they can understand. So Alex, as we think about disparities in health literacy, what are some of those groups that have a higher risk for having low health literacy?
I mean, the one that comes to mind, I think, for everybody is lower SES. Where is it a schooling issue? Is it a comfort with schooling issue? Is it a literacy issue in general? I mean, to be health literate, you have to have at least some basic background and some math, science, not statistics per se, but understanding percentages, measuring, etc. So I think that there is there's a lot of literature that shows SES. We also see a lot of immigrants, like, for example,
I see Marianne is like chomping at the bit.
I'll go ahead, Marianne.
I know why.
Mike and I both want you to explain SES.
Oh, but this is a CME podcast.
Yeah, but I didn't know what it meant.
Yeah,
Right,
so socioeconomic status. So it's essentially, your environmental and material sort of status.
I knew what you meant based on the context of the conversation. I knew exactly what you meant, but I have never heard it shortened to SES before.
I think a fairly commonly used term, maybe not, which means essentially socioeconomic status. And it's where do you stand, not so much economics per se, but also neighborhood, higher risk areas. There's some folks that have actually also looked at like ACEs or adverse clinical experiences or childhood experiences to kind of like also rank things on a SES scale. So essentially, the more risks that you have in your life, either financially, neighborhood, family structure, etc., seems to have a correlation with health literacy. I think that's the one that most people think come to mind right off the bat. But you can have somebody who doesn't even have a GED degree who can be very health literate, and you can have somebody with a PhD who is not health literate. So there is not a one-to-one correlation. So while I think it's a risk factor, it doesn't mean that it's essentially, a one-for-one. I think another group that we tend to not think about a lot, but makes sense, are immigrants. And even immigrants who speak English well may not know all the nuances of medicine. And I'm Ukrainian. And my parents came over, and my parents were very fluent in English, having grown up here starting as teenagers. But there are some medical phrases that would run by my dad or my mom, and they like just stare at me. And they spoke English, but it was just some of the slang or some of the medical terminology that growing up here, I knew, but even though they were fluent, they just struggled with. So for people who aren't even like fully fluent in English, it's hard to kind of get that nuance across. And we've noticed with interpreter services at the clinic where I'm at, we have a lot of Arabic families, and the interpreters don't always get what we get. And sometimes the families will just kind of like take what the interpreter says. And we have a few residents who understand Arabic, and they're like, that's not really what I tried to say. Let me try that again. So even having interpreters in the room, there's a certain nuance to explaining things to families where you have to stop and, did I just get the words across, or did I get the actual meaning across? So I think it's a population that's starting to be looked at. And it's about a fifth of all Americans now that English is not their first language. And so even if you're fluent, you may not actually understand the intricacies of either slang or more sort of phrases that we think everybody knows, like SES. So.
Yeah.
I think it's also the fact that many people who are immigrants and refugees come from different health cultures or countries with different cultures or health systems. So our health system is really very different and hard to understand for everyone, including me. So that feeds into it. And then you superimpose all those things that Alex just talked about. And some languages don't even have words for some of our concepts. Like prenatal care is not a word that is known in the Afghan language. So just to talk about that can be challenging. And then people have been exposed to torture and other really terrible things in, quote, health systems in some countries that they're coming from. So trying to take all of those factors into account.
And I think we tend to think of health literacy as just understanding a medical term or a management plan, but it's also understanding, like you mentioned, a medical system. We have people come to clinic, and it's commonly seen with a lot of our South Asian families where you have a one-stop shop medical center where you see somebody and they take your biopsy and they prescribe you, your chemo all in the same building. And we've had a few patients come in, their child has a lump, and they're like, well, are you going to do a biopsy now? And it's like, you have to go to derm. And well, can I go to derm today? Well, that's a referral. And that concept is very foreign to them because in their medical, especially in their rural medical system, you would just walk down a hall to the surgeon who would then take a biopsy, send it to the pathologist down the hall, and a week later let the family know. And here it's months long. It's frustrating for them. And they're like, then why did I see you? Because like my job is to get the ball rolling. It makes no sense to a lot of people. So I agree. So part of health literacy is like, this is how the system works, albeit not always well, but how the system works here in the States.
And there are multiple studies that show those who don't have English as their primary language are more likely to experience medical errors and poorer outcomes. So the data are pretty clear that is a risk factor.
Yeah, absolutely. So lots of risk factors that we've mentioned. Because it's a pediatric podcast, we've not mentioned that senior citizens are also at higher risk for a low health literacy. So something else to keep in mind, especially as you're interacting, even though you may be a pediatric provider, you're interacting with folks in your family and in your community. So just be aware that senior citizens are also at high risk. Back down to our end of the spectrum with pediatrics, what are some aspects of health literacy, Alex, that are unique to pediatrics?
I think the easy one is that you're dealing with two sets of people. You're dealing with the child as the patient, and you're dealing with the parents or the family as the provider. So that's easy. I'm not going to spend a whole lot of time on it, but looking at it like into three groups, for the nonverbal children or for the children who cannot express themselves well, they're really relying on the parents to kind of convey what they're thinking or bothering them to you. And if the parents cannot do it, then it's a problem. I have a case that kind of sits in my head that I've seen 7 or 8 times in clinic where this infant kept on having spit up and mom kept on, using a term that made it sound almost like pyloric stenosis, but it was just regular spit up. And of course the baby can't tell me, baby's growing gray, looking happy, a classic quote unquote happy spitter. but I ended up getting 2 ultrasounds. And I think a lot of it was just because this family didn't want to use an interpreter and they're trying their best in English. And I was thinking worst case scenario. And all of a sudden, they took time for 2 ultrasounds. And in retrospect, that I need to order one and then another just because, the first one was kind of like, most likely not. So I was like, I hate those readings. So I was like, I guess I'm going to send you again. This doesn't get better. But that was like a classic example of that baby couldn't tell me. You're relying on the parents to tell the provider. And there was a disconnect, and we either tend to undercall or overcall depending on the situation. Looking at kids in the mid-range, so like, late elementary, middle school, they may not be able to get help from the parents to sort of express their needs in better nuance. So the kids can start telling you, I have problems with my eye. So another case, I had a child who kept on saying, I have a problem with my eye seeing. And mom tried her best to explain it again. Immigrant family. And then finally, I asked for an interpreter and he's like, I can't see on the lateral aspect of my eye. I ended up having an abnormality of the retina. But it was one of those things where, like, for the first 15 minutes of that visit, it sounded like he just had allergies or like, poked his eye or something. And they were doing the best they could. And you can tell the kid's frustration that I want to tell you what I have, but I don't know the language well enough. He doesn't know what lateral means. And the parents obviously didn't know it either. So until we got an interpreter, and then he's like, I can't see out of this part of my eye. And then I was like, oh, that completely changes how I'm going to approach your case. And then for teens, if parents are not health literate, there's been some work looking at, teens and parents have a unique relationship to begin with. And a lot of it is sort of like teens becoming independent, but still trusting their parents when it comes to major decisions. And if they're like, well, my parents have no idea what they're doing when it comes to health, I'm not going to trust them when I see my physician. And for a lot of chronic illnesses, you really need that parent and the family involved to help that child or help that teen with their health care. But if you can't trust your parents because they don't either understand or, really know how to help you take care of yourself, then you get a disconnect. Now it's just between the teen and the provider. They're not seeing the provider every day, but they see the parent every single day. So, and that's why I think from a pediatric perspective, I think health literacy across the board at all ages makes a difference in different ways.
Yeah, absolutely.
Yeah, to piggyback on that, what Alex talked about, those 3 different sort of age groups, there's the whole developmental aspect of a small young child evolving to be the primary manager of their own health, say asthma or diabetes or allergies, whatever, that the child, we get used to talking to the parent gets used to supervising everything, and suddenly you've got like a 16-year-old who's not at home. They're at practice and they're at school and they're doing all these things, and we aren't focusing on them to make sure they understand what they need to know and do for their care. And then when we get to that issue about interpreting, we're also talking about people's need to, why we have to use professional trained interpreters and not use children as interpreters, because that becomes a power differential and a problem when the parent has to rely on the child to convey health information.
Yeah. And that child may not understand the nuances of what y'all are talking about, and things can certainly get lost within the words for
there's
sure.
Private information or embarrassing information. Kids don't want to say a word like diarrhea, like, oh my gosh. There's a lot of power dynamics there.
So we've spent the first half of this podcast really defining health literacy, explaining why it's important. And so the next question for us as medical providers is really, what can we do, that's within our control to improve health literacy among our patient population. So, Marianne, what are some strategies for improving low health literacy?
I think that's the question, right? We have years and years worth of really good data to show that limited health literacy is a problem. And so we have this responsibility to address organizational health literacy. How do we communicate effectively with patients, families, community members? And I talk about several key things. One, going back to that 90% of people struggle with our health system. we need to use the universal communications principles, universal precautions approach to health literacy, recognizing that many people struggle, but everyone can struggle depending on the circumstances to understand and remember. If you've been up all night, if you yourself are sick, you're worried about your child, if you're a pediatrician and it's a parent who's 80 years old, there's many, many reasons. So we need to use these common, clear communication strategies with everyone, because we don't want to be saying, well, I think you understand and you don't. It's just we communicate clearly. We use plain language in what we say out loud and in our written materials and in designing our things like our signs. And then when we do that, at the end of the day, the bottom line is we make sure people understand. And that's where we use the technique called teach back. And I always say, if you do nothing else, use teach back. So teach back means that I take responsibility for being clear. I'm not going to be quizzing you or putting you on the spot. I want to make sure that I explain things well. So I'm going to ask you to explain it back to me using your own words, not just repeating what I said, so that I can make sure I did a good job. And that's how we, at the end of the day, make sure that that parent with the child with the cold knows that getting better means this is what's going to happen over the next week or two. The parent who needs to have a biopsy knows when and why the next step is going to take place. So circling back, using teach back, and then re-explaining if they don't understand and checking again. And always using trained interpreters. Don't think, oh, they probably understand or they don't want one. It's our policy to make sure that we can communicate clearly, so we want to have a trained interpreter. So I start out with those universal precautions, plain language and teach back.
So as we think about plain language, it would be easy to assume that by using plain language, we're simplifying things. We're making it simpler, but that's not necessarily the case, right? I mean, you can explain very complex topics using plain language. In fact, Albert Einstein said, if you can't explain it simply, you don't understand it well enough. So, and I don't like the term dumbing it down, but I think sometimes we feel like when we use plain language, we are making it too simple, but that's not the case, right, Marianne?
Not at all. And just that phrase, I don't even like to repeat it anymore. It's not baby talk. That it's recognizing that we have our own specialized vocabulary that we need to use with our teams. We also speak the language that everyone else speaks, and it's our responsibility to be bilingual, to be able to move back and forth from technical terms to everyday terms. And that kind of ties in with, even some of the disparity work, but even not that. When we know that this is an issue, when we continue to communicate in complex ways, we're choosing to not communicate clearly. And that's not what we're about. We're about communicating effectively to achieve good outcomes.
Yeah. So in terms of thinking what this looks like in a very practical manner, Alex, how do you use plain language in the exam room?
I just want to reiterate what Marianne just said. Our job isn't to communicate clearly, but clearly and effectively. And I've been at this a long time, started residency in 90. And my very first rotation was at Crozier-Chester, where all of us had to do at least 1 month outside of Philadelphia a year. And the attending there, the head of pediatrics there is a gentleman by the name of David Baker, who I absolutely loved, who passed away about 10 years ago. The very first patient I saw with him in clinic had most likely appendicitis. And it was a very poor family, recent immigrants, I think from like somewhere in the Caribbean, so mostly French speaking, from the country they were from. And I was like, how's he going to explain appendicitis? I mean, literally, very first patient I saw in clinic with him. And he basically drew on the table a belly. He got the sibling to lay it out on the table and showed the parents where the appendix lives. He uses pinky to show that the appendix is about half a pinky size. Did a nice job of explaining, like, we have no idea why the appendix exists besides getting infected. And then this is why he thinks it's infected. And it was just brilliant. I mean, he didn't say a ton of words. He used a really bad drawing. He drew worse than I draw now. But he used the other kid in the room who then was engaged and wasn't running around the room, because now all of a sudden he is part of the conversation. He asked the parents several times, what are you concerned about? And then when he brought up the fact, I'm going to have to walk you down, the nurse had to walk this kid was not doing well, to the ER, most likely for surgery, and have to ambulance you up to Philadelphia. He just did such a nice job of being clear, using multiple terms, and in a 10, 12-minute visit, everybody left that room knowing exactly what the next step was. And that really ingrained, that was patient one, day one of intern year. And that left a huge impression on me. I would just beg to go to Crozier Chester to do clinic with Dr. Baker, just because, and he also did urgent care. He was just brilliant at just communicating. So I try to do similar things, is use another sibling as the quote unquote anatomy. Show on myself, I think you broke your finger. Let me show you how the finger works. Draw on a piece of paper. And I'm a horrible drawer. So if I can get away with this, then people who have any sort of fine motor control, which I don't have, can do a better job. And then reading the room. And if the parents are really concerned, like I once told somebody, your child has scarlet fever. And the parents looked shocked, because there was an outbreak of scarlet fever in their country about 10 years earlier that had killed about 1,000 people. So for them, scarlet fever was a death sentence. For me, scarlet fever was group-based strep with a cool rash. So I was like, okay, let's back up. And then it's a matter of reading the room. You see the shocked look in their faces. Then scarlet fever is a type of strep throat. It just has a rash. Instead of, I should have said that first, but you correct the mistakes as you move forward. And then a lot of what Mary Ann brought up is this teach back, is after every one or two main points, just stop and say, do you have any questions about, and then summarize quickly. I think your child has group A, has strep throat that has a rash. I can treat it with an antibiotic. Any question about that? And then you talk about the antibiotic I want to use is amoxicillin. It doesn't taste bad. This is how much you have to give for how many days. And just stopping and doing teach back. It's hard to do in a busy clinic and busy urgent care. But study after study shows if you're effective and the parents and the child leaves having a good understanding and a mutual understanding of what's going to be the next step, they won't come back. And if they do come back, you know them, and all of a sudden there's a trust. Like, okay, you explained the broken finger to me well last time. Now I'm concerned about a, possible appendicitis. And now there's a trust already built. And so in the long run, it actually makes the flow of the clinic so much easier if there's that trust built. So, but teach back, chunking it down, and reading the room, and use your visuals. So, Dr. Baker had all these little anatomical books in his clinic room. He would just take them out. Just this is what an ear looks like, and this is why it hurts. And, it was just an amazing job. So,
Alex, I want to thank you. That story you described with Dr. Baker is beautiful. And it's just touching to hear the story, and to hear that was your first patient as an intern makes it even more incredible. And you described so many of the techniques we can use to make things more clear. I hope he tore that paper off the exam table and gave it to them to take home, because new readers, adults learning to read, say they really want that picture to take home. Please don't wad it up and throw it in the trash when you leave. So, and I also love the technique with the sibling, because people talk about, we know that's a distraction when the sibling is running around or talking, and it makes it hard to focus the message. So that was a really nice add. And then you talked about chunk and check. That's the technical term for pausing every couple key points and checking in, and ideally using a teach back. Can you tell me, that was a lot of information. Can you tell me the medication that you're going to be giving and how often or whatever? That's really great.
Yeah, it really is. I also want to point out that from a teaching standpoint, think of all of the kids that Dr. Baker is going to impact in his life. Not that he has necessarily seen, but the impression that he made on you, Alex, and then the impression you make on your learners. All of those kids benefit from that one experience on day one of your intern year. To me, that's incredible.
He's like the Coach K or the Bill Parcells coaching tree. They always mention, this one coach then spun off all these assistant coaches. And so, that was Dr. Baker.
Yeah, that's so cool. The exam room is not the only place where we have an opportunity to improve health literacy, especially in this digital age when we have more and more pediatric providers also becoming content producers, such as myself with PediaCast. But there are plenty of blogs written by pediatric providers, social media accounts and engagements, infographics that providers make, TikTok videos, short, little longer videos that are educational on YouTube. So, Marianne, as we think about both traditional educational materials that's printed and digital stuff, how can we use plain language in our teaching of parents and families and children?
You're talking about so many of these other ways we communicate, not just the verbal, right?
Yeah.
I've got several, I think, really helpful ideas. And I before we do that, I wanted to again underscore the Dr. Baker piece, that role that we all have to role model the right behavior for our residents, for our students, because they learn this. They're learning more of it in medical school and nursing school, et cetera. But if they start doing rotations and come and follow us or shadow us or see our patients with us, and they don't see us using it, then, oh, I guess that was just something I had to learn for the test, right? So our responsibility to role model, I think, is really important. And then when we get with, whether they're handouts or visuals or electronic digital communication, we still focus on these features of reader-friendly materials. It used to be sort of paper handouts, but now it's all these other things. And getting oneself familiar with what are those characteristics, not that you're going to be designing all these handouts all the time, but being able to recognize what makes a handout good, or if you're asked to draft something, how to arrange the material so that it's attractive and inviting to read, and people don't just say, oh my gosh, and throw it away and don't even give it a try. That's important. And then there are tools. The CDC has the Clear Communication Index, and AHRQ, the Agency for Healthcare Research and Quality, has the PMAT, assessment of educational materials, and they have that can be applied to written handouts, but also audiovisuals and electronic communication for a variety of audiences. So those help you assess a document or a handout or a podcast or a blog to see whether it's inviting to read, reader-friendly. It's not all about reading level. You could have a reading level of 5 with a bunch of gobbledygook because it's got 3-letter nonsense words in it. It's all the other pieces that contribute to that. But I think not that you have to run every sort of document or handout or tool through these, but it gives you an objective measure, and you could do a sample and look at things over time and see if they're improving. They help identify areas where you could improve them, getting rid of all this extraneous words, using bullets and more white space. And then even if we only have a complex text-dense document, at least circling and marking it up and putting a star by the most important information, telling them what you're doing and pointing that out to the family when you're in the room with them or when you send them something on a portal or whatever. All those are ways that we can help them find and share that information and remember it later after they leave or when they want to share it with their families.
One of those systems that you can put your writing into, and they have a free version, and I don't get any kickback. It's just a product that I have used in the past and have had personal experience with, is called ProWritingAid.com. And I'll put a link to that in the show notes so folks can find it and check it out. But they, like I said, they have a free version where you can put something through, and then they have paid tiers as well to get more information about what you've written. And it goes way beyond just grade level, as you mentioned, Marianne, and looks at for passive voice and lots of things. So something to check out, especially if you write on a regular basis. And then, just as we talked about interpreters, I think it's important to have educational materials in other languages. Even here at our hospital, we try some of our the AVS is the after visit summary. Parts of it will print out in other languages, but the parts that we type in ourselves does not translate. And so you just have to keep in mind that, if you have non-speaking patients and you're giving them educational materials, you want to make sure that they can actually read, understand what it is that you're giving them. And so you got to keep in mind is, if you have a large population of Somalis, for example, do you have patient handouts written in their language?
And sometimes videos can be helpful. Again, some languages don't have a written language, or people may not be literate in their native language. So sometimes a video can be helpful. And I've worked with several folks here at Children's who are starting to develop those, and not just throwing it together, but looking to checking to make sure that they're using plain language in that video.
Yeah. I was at a planning summit just yesterday, and this came up where you could have a QR code that would go to a video library in particular languages. So in addition to our written helping hands, I actually have videos that folks can watch that can be done in their language. And that would be so incredible, and yet a pretty easy thing to create other than the time that it takes. But I could definitely see a use for that. So Alex, going back to Dr. Baker, how do you now incorporate plain language in your clinical teaching?
I think clinical teaching isn't just teaching residents or medical students. It starts off with teaching patients and families. And then I think a lot of the role modeling, a lot of like using multiple visuals, and really trying to read the rooms is a good way to at least start off with families and patients. We have a really enthusiastic nursing staff at Olentangy, and they really do want to help with the teaching. And there's a few of the nurses have done a great job of learning like side effects of vaccines or how to give medicine properly, and helping teach them and then see them do a great job teaching the families. So now a family knows exactly what 5 mLs of Tylenol means compared to just me writing on a piece of paper. They'll walk in with a syringe, or they'll walk in and say, do you understand, how often to give? And they'll show on a clock. And so a lot of the clinical teaching also, you use the people that you're with. And then lastly, I think a lot of residents learn, they're overwhelmed. They run to clinic and then they run back, and, there's always no's, and they're tired a lot. I think we all remember those days, but, a lot of it is just the role modeling, just kind of let's go into a room together and work through a hard case. And one of my most astute, most amazing residents ever, one of her last weeks, had a child that was going to be a brand new diagnosis of severe autism for a family that was really fighting this diagnosis. And she's like, you go in there, you explain, I'm going to watch it. And it was just the two of us did, I think, a decent job of explaining not only the diagnosis, but the next steps. And that's where it comes in handy just to kind of learn from each other. And she was one of the, very profoundly sensitive person with the families. And I think they picked up on that. And then they picked up on the back and forth, and just the two of us learning from each other. How do you actually talk to a family, non-English skills, through an interpreter on a diagnosis that they don't want to believe? And I was role modeling both ways. It wasn't just me role modeling; it was the two of us working together to get this done. And sometimes, especially with residents, because a lot of them are very senior when it comes to experiences, is working with them as well to kind of bring up a nuanced topic. So.
Do you find that the nursing staff, when you're modeling plain language and teach back, a lot of times the nurses aren't necessarily in the room when we're doing that, and yet nurses often take phone calls and engage with sometimes as many patients a day as the providers are engaging with just on the phone, answering patients' questions. And so I would think that as an extension of your practice, that nursing staff really ought to also be on board with using plain language, doing teach back. Have you given any thought to that, Alex, in terms of how do you make that happen?
So I'm involved with the Academic Pediatric Association's Continuity Clinic group, or the Continuity Clinic SIG. And something that is always brought up is a team huddle before every shift starts, which is, we don't do, let's be honest. It's just, things just kind of deteriorate quickly. But I think every so often, just meeting with the staff, especially at all in Tangi, one or two of the nurses do all the phone calls. So there's six or seven nurses on any given day, nurses and medical assistants, etc. And one or two of them are assigned to do phone calls. Monday is usually 2, Friday is usually 2, and the other 3 days, less phone calls. But even like during lunch, they'll say, okay, I got a couple of phone calls where parents are really concerned about COVID testing, like everybody's worried about COVID again. What do I tell them? And just sitting down with the two of them, myself, and if the resident on continuity clinic block is available, just to kind of talk it through. So we're all on the same page. And I can hear in the background some of these phone calls. And then like, what did you think of that phone call? But for a harder phone call, like, how would you do the first one over lunch? I'll listen to what you say, and then I'll take it from there. And so a lot of it is just a communication back and forth. It's like anything else of being human. Like when you're coaching a basketball team, you can have all the best drills possible written out, but it still boils down to reading the room. How am I going to teach you how to do a layup? And how am I going to then find a few people who do layups well to teach the other ones who cannot do layups, so we don't spend literally the entire practice just doing one drill. So it's a back and forth, and you get people involved that have either a talent or a desire or both to do it.
I think to just develop a couple of those ideas that Alex just hit on, it is a team sport, right? And using plain language and teach back is everyone's responsibility that interfaces with patients, families, community members, even if they are on the phone in the billing office, or the housekeeper who may get questions from a family, or who may pick up on reading the room, who may pick up on the fact that after the doctor leaves or the nurse leaves, the family hasn't got a clue what was just said. So empowering them to tell someone and said, I'm really concerned that the family in room 203 didn't really understand. Could someone talk with them? And also, what is the most important information? They're not going to understand and remember. They're not going to remember everything we say, but again, Alex's points, what are the 1 or 2 most important points? And circling back, checking, using teach back. I want to make sure I did a good job explaining this. I want to make sure you're comfortable. Can you put it in your own words? Because that's how we know. You don't ask the kid, do you know how to do a layup, right? You watch him do the layup, and then you can continue to refine his or her layup.
And I agree. I think one or 2 things to remember, and then also, when should you worry and come back? I think we're all parents here, is like, I want to know, like our son had surgery. And I remember my wife asking, when do we worry about this getting infected? I mean, she lives with a pediatrician who does urgent care. So, but she's like, my husband's probably going to be at work at some point if this starts to turn red and get like a straight red line. When do I rush back, and when do I essentially? And the orthopod did a great job of saying, this is when I need to see you back urgently, and this is when I need to see you. I think every family needs to get that. You have a head cold, this is going to last 3 or 4 days. If they're not drinking, eating, having a really high fever, I need to see you back sooner. Or if you're not better in 5 days, then come on back. And I think parents just need to have a really clear expectation, and kids also, of this is what to expect. I think we're so focused on diagnosis and not focused enough on outcomes and expected course of an illness. So, but medical schools have to really focus on outcomes, not on diagnoses.
There's a health literacy tool called Ask Me 3 that, again, right out of Alex's mouth, the 3 most important questions that people need and want to understand, and that we need to make sure they understand. What is my main problem, or what's the main issue? What do I need to do about it? And why is it important? And that's exactly what you were just talking about. What do I have to watch for? When should I call the doctor? What do I do to look for that? And it's important because blah, blah, blah.
Yeah.
And if you involve the whole team, it doesn't have to be a time sink. It's not just the doctor's job or the nurse educator's job. It's everybody's job to make sure people understand and to be clear. Yeah. And then at the end, to kind of wrap up and say, what questions do you have? To make it very clear that everybody has questions. Do you expect questions? Not do you have any questions? Because they can shake their head no and say, I don't know. What questions do you have? Give them to me. So just shifting that language can be powerful.
And keep your hand off of the inside of the doorknob when you say, what questions do you have? I mean, you want to really encourage them to ask the questions and not be like, I got to get out the door because there's 5 people in the waiting room. And chunk and check. So this is terminology that I've heard for the first time today. More terminology. I love that though. And that would open up a great conversation with nursing staff, like just, over lunch, like, hey, have you ever heard the term chunk and check? And then, then you can explain what that is, and maybe they'll start doing it on their phone calls. Hopefully they will.
I wanted calls are important, right? I mean, you can't read the room very well in a phone call.
Yeah.
And so that's even more important to double check that they understand and to check each of those key points, not just do this big giant thing at the end.
We want to leave folks with some resources that can help them improve the health literacy of their patient population and incorporate plain language into clinical encounters, educational materials, and clinical teaching. So, Marianne, what are some additional resources that folks can look for to help raise awareness and improve health literacy?
There are both CDC and our Agency for Healthcare Research and Quality both have health literacy sites on their web pages that have research and data and policies and tools to help sort of in that academic frame as well as real world implementation. So those are really good sources of that kind of information. And also their ARC offers the Health Literacy Universal Precautions Toolkit, which is a really great practical implementation guide to use this principle of universal precautions, addressing clear communication with everyone in the clinical setting. And it's full of tools. And there's a teach back tool, and there's plain language tools for written and oral. It's a little bit tailored to outpatient, but you can just tweak it a little bit and apply it for other settings like inpatient as well. There is the Always Use Teach Back Toolkit, which is an online resource about Teach Back. There's the guidebook for promoting organizational change to help promote organizational health literacy. The Institute for Healthcare Advancement has a health literacy health literacy solution center with a lot of tools, and IHI also has some health literacy tools as well. And Ask Me 3 is, I think, available through IHI as well. So those are
and we'll put links to lots of these resources in the show notes for folks so you can find them easily. Just head over to PediaCastCME.org and you'll be able to find those in the show notes. I also, Marianne, I know you are going to be modest here, but you and Dr. Bernard Dreyer with the American Academy of Pediatrics co-authored a book called Plain Language Pediatrics, Health Literacy Strategies and Communication Resources for Common Pediatric Topics. And we'll put a link to that so folks can find it in the show notes. And you also wrote a fantastic blog for 700 Children's called Health Literacy and Partnering in Your Child's Care. And we'll put a link to that as well. And then I also want to mention those 21 episodes of PediaCast for Parents that the three of us collaborated on. And we called it our Pediatrics in Plain Language show within a show. And those 21 episodes are all together as a library over in SoundCloud. And I'll have a link to that playlist for folks, again, in the show notes of this episode, 89, over at PediaCastCME.org. Before we go, we have lots and lots of listeners who are not in Central Ohio. And Alex, I just wanted to give you a chance to kind of brag and boast about primary care pediatrics at Nationwide Children's Hospital, because we really, really have a fantastic primary care program. Tell us a little bit about that.
Yeah, so we're big and mighty. So we have 14 brick and mortar clinics, like your traditional clinics, and 5 of them are for Gen Peds residents. 1 to 2 have family medicine residents, and then 1 has our IMPs residents. And then the other 6 or 7, depending on the family medicine needs, are standalone attending clinics. We have several dozen school clinics in various forms. And Dr. Bodie, one of our colleagues, actually helps run those. We have a mobile van that visits various locations in the area. So the system in general sees well over 125,000 unique patients. I think we're approaching 300,000 visits total. So it makes us the biggest academic primary care clinic system in the state, in the country, in the world, in the galaxy, and in the whole universe. So we are big and mighty. No.
And we'll put a link to primary care pediatrics at Nationwide Children's in the show notes so folks can find it. All right. So once again, Dr. Marianne Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital. Thank you so much for taking time out of your busy days and spending it with us.
See you guys.
It was a great discussion. Thanks so much.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks once again to our guests this week, Dr. Marianne Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Also, our landing site is available over at PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, our CME information, terms of use agreement, and a handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, and LinkedIn. Simply search for PediaCast. You've listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. It's really easy to do. Just head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy. And again, we do offer credit to many pediatric professionals, not only physicians, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Complete details are available at PediaCastCME.org. Also, don't forget about Plain PediaCast, our evidence-based podcast for moms and dads. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.